Good afternoon, everyone. It's 3 o'clock here in the afternoon in the UK on a Wednesday, so that must mean it's time for an IPC Journal Club. And it's going to be a good one today. I'm delighted to say we've got Professor Martin Kiernan with us. So Martin, are you a professional broadcaster now? Is that?
Yeah, no, not well. It's about all I am, to be honest, these days. But yeah,
So
not quite.
Of talking IPC Matters podcast and other broadcasts. So it's great to have you with us, Martin. We're looking forward to hearing what you have to say. Your topic today is simulational slides, rethinking the IPC training role. And I put a little blog out yesterday about this, and it's got a lot of interest. So I think there's going to be lots of interesting questions based on what you have to say today. You're going to be speaking to us about a paper in AGIC, infection prevention is current and preferred training strategies and tools. So just before I hand over to Martin, I'll just run through some of the basics of the Journal Club, what it's about, what we're trying to achieve. So we always try and make it some discussion on a topical paper. We want to provide opportunities for CPD for you to think about what we're talking about, and for it to ask some questions in your own minds, really, to build some questions for your independent study, to foster a network of enthusiasts, and in an ideal world, have a little bit of fun. So with that being said, I will hand over to Martin to talk to us. Thanks, Martin.
Thanks very much, John. Thanks very much for the invite. Just check that the slides are up. Can you give me a thumbs up, John, if they're up? Perfect. Okay. So simulational slides, IPC training. Yeah, it's one of the first things I worked out I should do a lot of. Because when I started, when I were a lad back in 1990, there was me for probably about 1,000 DGH beds. I had all the nursing homes. I had a couple of long-term care institutions, proper institutions for mental health, learning disability. No computers, no data, no microbiologists. It was a part-time microbiologist, and it was okay, so I am about 0.0001% of the workforce, and I don't do infection control. I was called an infection control nurse. Other people have got to do infection control. So I worked out pretty quickly that I needed chums, and I should be trying to educate other people. So I spent a fair amount of time on what I thought was education. Now, what I should really make clear right from the off is that I'm not an expert in any of these topics. Educational psychology, pedagogy and andragogy, instructional curriculum design, etc., etc., etc. Plenty more people who are far more expert in this. And my teaching and educating training came from I think it was an EMB 910 course, no, 998 course, and that was it. And that was undertaken in the last century, well before into the last century. And from that, I had to build training programs, etc., etc. And I spent a fair amount of time on it, to be fair. Did it work? We all know that education and training is regarded as a pivotal measure to reduce the risk of healthcare-associated infection. Walter Zing had it as one of his 10 components of hospital-level infection prevention and control. It's the WHO core component number 3, although interestingly, there is a differentiation in that between primary and secondary care, where you should definitely be doing training on higher and tertiary care, where it should be annual. And I do wonder about that, because I think everybody could do with some form of at least annual update. And we developed quite a lot of time to this, but how effective is it? Interestingly, the effectiveness of IPC training there's not a lot of literature. And Deborah Ward, who was a senior lecturer at Manchester doing her PhD, did a systematic review on this. Published it in Nurse Education Today. Now, I know this is a few years ago, it's 12 years ago, 13 years ago, but reviewed 39 studies on education in prevention and control of infection, and found that there was no clear evidence of any sustained positive effect on compliance. And I think we can all, apart from obviously hand hygiene, which hits 100% compliance, and so we should really never need to educate on that subject again. So we've got no clear evidence that there's any significant or sustained effect on infection rates, and it was felt, Deborah felt it was questionable whether knowledge actually improves practice, because there's other human factors in the way. So we haven't got great evidence. And if you actually go looking at studies that are talking about effectiveness of training. Here's just an example published in BMC Infectious Diseases. It's open access, so you can easily get at it. They did a couple of point prevalent documentation reviews a year apart, and they had done some training to improve central line care. And they got a subjective reduction in inappropriate catheterization, and they got better documentation of insertion and dressing change. No reduction in the infection rate at all, but their program was, there was an online teaching component and pocket leaflets and posters. It wasn't compulsory. They have no idea who did it. Completion rates were not recorded, never evaluated, and shockingly, it didn't work on infection rates. And I've heard people saying, well, we could spend an awful lot of time on training. What happens if we train people to a high level and they leave? I've always felt that what's more worrying is if we don't train people and they don't leave and they stay. And one of the few things I agree with Richard Branson about is his comment was train people well enough so they can leave, treat them well enough so that they don't want to. But unfortunately, as we all know, when times are hard in infection prevention and when staffing levels aren't high enough, education is normally one of the first casualties. So that's a problem. So I ended up resorting to good old mandatory training day, and people were bringing their pillows along. I worked out I delivered about 1,000 in-house training sessions in my career, and I have no idea if they were effective. People seem to like them, so that's all right then. But did it change anything? I've actually got no real idea because I wasn't evaluating it. I mean, I suppose the one thing I would say is when I started in infection control, if we got a norovirus outbreak, about half the cases we saw was staff. And by the end of my career, when we got a norovirus cluster, hardly any was staff. So I'm inclined to claim that as a success that people had got a bit better at infection prevention and control, because norovirus will always sniff out your weak links in your organization. And some people like Chris Pearl have done some work on competency-based training and tried to evaluate mandatory training. And they did some questionnaires with people from various different occupations and professionals, and mixtures of hospital units. And they looked at people before and after orientation sessions. And they looked at, did people retain the knowledge? And they looked at elements that actually captured knowledge, practice, and attitude. And attitude, I think, is really key because that's something we rarely talk to people about. If the attitude is not right, then people are much less likely to learn. So they set out some multiple questionnaires. Actually, questionnaire design is another topic, but I'm not going to go into that today. They reckon that by September 2007, they trained 86% of their hospital staff. They sent out a number of pre and post-test surveys. They did some retention surveys as well. And they got a significant difference between pre and post-test. And there's a p-value there, so John will like this because he does like a p-value. So pre-test, correct answer 1 in 3, over half post-test. Notice it's still nearly half got it wrong after the training. And what they didn't do was evaluate the training to find out why it was only half. Was it sustained? Yes. Well, actually, knowledge at 1 year was actually lower than pre-test. The retention test was at 3%. So that's not great at all. So the knowledge gained throughout this is very short term. So either you keep repeating the same message, which for some staff is extremely boring, or you're going to keep doing re-education at shorter intervals and finding better ways of doing it. And what some have reported, and this was a nice short paper published in the Canadian Journal of Infection Control, was that actually, if you look at nurses' needs, then they tend to learn more. So actually ask the staff what they feel they need to know. I mean, sometimes they don't necessarily know what they need to know, but I often find when I'm designing a training program, well, I've been guilty of it, I design what I think they need to know. And if they don't necessarily want to learn that, they may go about it learning in a different way. If you get what I mean, people are much more willing to be receptive to something if they feel that they need to do it. Yeah. And the other thing I'd like to make a quick point about is that Diana Gould was involved in this paper. It's a few years ago again, but post-reg learners report that their preferred way of learning is by teaching by knowledgeable experts who are prepared to discuss issues that arise. And that's the sort of thing that I'm afraid individual e-learning is never going to help you with. And I'm afraid also some universities have resorted to using generic lecturers to teach infection prevention, and they're very going to really struggle to discuss issues that arise, I think. There we are. So what about current practice then? Let's look about this paper that's recently been published in AGIC. So it's education about what current and desirable practices are. And again, they're saying it's a core role, so that we are at one with that. And APIC, the organisation, sent out this questionnaire, and they got nearly 2,500 respondents. So that's good. That's a really good response rate. So it's something clearly people are engaged with, probably because they're doing it. What I thought was interesting is this is a 2023-2024 survey. Just over half of them actually had less than 5 years in the specialty. So I suspect, like we are experiencing here in the UK, is there's an awful lot of new people came into infection prevention or were forced into or ended up in infection prevention and control during COVID. And so there's over half the workforce has less than 5 years experience. And if you remember Benner's work from knowledge to expert, it does take quite a while to develop that expert practice aspect of it. And I suspect we've lost a few senior people who decided to stay on for COVID and left the scene pretty quickly afterwards as well. And what the COVID pandemic did was shifted our focus from training to crisis response, which then really exposed training gaps. And we had this high turnover of new people entering the field with limited mentorship during the pandemic. And what we found is that the new people learned pandemic infection prevention and control and not the more traditional infection prevention control, which I do wonder as why the most recent S4 report in the UK has shown that healthcare associated infection was now running at 8% in England. It had previously been 6%. I'm a bit surprised there hasn't been a lot of comment about that, to be honest, because that's quite a significant increase in healthcare associated infections. And I would have thought people might have been a bit more jumpy uppy downy about that one, but there we are. So anyway, they decided they were going to send out the survey. The objective was to look at the frequency and methods of infection prevention training by their practitioners, and then ideally look at some preferred training tools and methodologies. And looking at the current practices, they were predominantly using impromptu training methods, and much more likely to report engaging in impromptu, i.e. just-in-time healthcare worker training and team huddles versus planned educational activities. So there was a lot of just-in-time feedback, and that may be talking to small groups, it may be seeing poor practice and having a word with somebody at that time, or maybe it's actually catching people at a small group meeting like a huddle. So and you get the informal consultations during rounding as well. If you're on the wall, people will ask you things, or you'll see a different type of infection. You maybe ask staff, do you understand what's going on here? And there's a chance to do some education on that. And they also found that formal planned trainings like new employee orientation was actually less common. And they were significantly less likely to be using train-the-trainer approaches, which have been popular, but they were less likely to use those. Now, interestingly, they found that the more junior infection preventionists were significantly more likely to be training just other nurses, but those who had the increased years of training and those more experienced were more likely to be training other staff groups and training prescribers. And the IPs with 2 or few years limited work experience, if you like, they were much less likely to provide informal training, and yet often these infection preventionists were the ones out on the wards. And they weren't going to be providing formal training in response to a change or training groups in response to concerns either. There were differences actually between the leaders of the group, in other words, the most senior infection preventionists versus the general practitioners, and they were much more likely to educate the non-clinical and the allied health staff and the staff with prescribing privileges, possibly because they have the experience to be able to answer questions, or maybe they have the authority or the status in the organisation in that their education is more likely to be well received. We've all come up against a very senior member of staff, and if you're junior, it can be difficult to get your message over. And the leaders are much more likely to conduct the informal training, i.e. answering staff questions, the formal planned training and the formal training in response to a change. Now, what I would say is, I think that I don't know if that's the case here in the UK. I'd be fascinated in the discussion to hear if the most senior member of the team actually does much training. If you're an associate dipsy or something like that, how much training are you able to do, or is it the rest of the team that's about to do that? Their training practices and preferences, their preferred training methods were simulation-based education and brief discussion. With the team huddle, they ranked highest, although interestingly, simulation was the least likely to be used. So, maybe that was I'd like to do it, but I actually don't know if it's possible and if it's going to be workable. And interactive and demonstration-based training was strongly favoured over formal presentations, independent modules, i.e. learning or train the trainer models, even though 93% reported having to use formal presentation, 3/4 saying that they were having to use learning in their facility, and 60% reporting use of train the trainer, because these are the models that many of us are currently using. Maybe this is the only opportunity you're definitely going to get to talk to the staff by doing a formal presentation once a year. We managed to get still retained face-to-face up until certainly the time I left Southport. Everybody got 1 hour a year, 1.5 hours a year of infection prevention face-to-face. It was tough, but we felt that was useful because people could discuss this with us, but maybe it wasn't because we never evaluated. The tools in current use, the tools and resources, were handouts and PowerPoint presentations. Unsurprisingly, videos were also frequently used. I'd be interested to know in discussion whether we use videos on this side of the pond or other people's experiences in other parts of the world. The least common tools, smartphones and tablet apps for training, possibly because it's very difficult to get on intranets in our organisations, or maybe the mobile signal isn't that great, depending on the design of the building. If you're in a big Faraday cage, effectively. And the least common tools also included simulation or demonstration tools. So it's a big technology gap because the most desired tools were simulation tools and app-based interactive training solutions, and we don't have access to that. Now, I don't know who would pay for that. How would you get the funding for that sort of educational method? The key findings on the gaps and needs were limited use of high-impact teaching methods like simulations due to resource constraints, and that resource can be time or facility, or they actually can't get in. Lack of readily accessible apps for IPC compliance and education, and need for us as practitioners to enhance our just-in-time training skills, because I was never given any training in just-in-time training, and how can we make this effective impromptu education to be as useful as we possibly can? Well, the other point I point out about these small just-in-time training skills is, how do you document them? How do you know who's had that sort of education? If you just seen an opportunity as a huddle here, I can rush up and I can educate. Do we go away and make a note of all those present and that we've actually given you some training? It certainly wouldn't fall into some sort of formal training. Do we actually include that in our annual report? We've given 375 small just-in-time training sessions this year. Does that go in your annual report? I don't know. Let's have that in the discussion as well. The desired enhancements, therefore, were increased access to simulation resources, development of apps, and training on creating engaging interactive educational materials. The other thing is you've also got to look at your staff group. Who you're dealing with and how is their best way. How would they want to learn? And how I might want to teach may not be the way a 21-year-old wants to learn. Well, in fact, I'm almost certain that would be the case. So there's a chance to enhance our learning skills that way as well. So recommendations and implications: investing in simulation tools, development of apps, integrating training. Implication for practice was aligning these approaches with our preferences to enhance the engagement, and then trying to leverage the technology and empowering us to develop high quality adaptable training. See, we work away in our own organizations, but we don't actually have good links in how to develop our programs, I don't think, with tertiary education centres who have actually got some experiences in curriculum design, etc. Now, if we're going to be doing just-in-time training, I just thought I'd talk a bit about the skills needed for effective just-in-time training. Critical thinking and problem solving, to be able to assess the situation, determine immediate training needs, and tailor to staff roles. And that probably explains why it's generally the leaders who are more likely to be able to do this, because they can sum up a situation fairly rapidly through their experience, look at the staff groups who are there and try and tailor it and get those messages over in the right way. Because communication, clear, concise delivery messages in real time is important, but also listening. Okay, and that's something I've been really quite guilty of in the past. I'm happy to teach or talk about, I get my message over, but I don't listen to what the staff are saying. Yeah, but what you're saying is that won't work. And what I should be doing is listening and think, okay, why wouldn't that work? And okay, well, you're telling me that wouldn't work because of this. If I could show you how it could work because of this, would you be interested in that? Would you be able to do it in that way? And maybe I have to tailor the message so that I can make it work for people. You know, adaptability, resourcefulness. You've got to be flexible to train in diverse environments, and whatever in available resources you've got, or do quick demonstrations. That's useful. Technical expertise you have to have as well. This in-depth IPC knowledge to give us the evidence base. You know, are our current practitioners in our IPC teams globally getting the education they need, because many of them are new? Are they getting access to educational programs to skill them up with IPC knowledge? Many people came in because they were motivated and want to make a difference, and that's brilliant, because to me that's one of the most important things about somebody working in infection prevention and control. We could teach you infection prevention and control, we can't teach you enthusiasm and motivation. That's really important, and having interpersonal skills as well, you know, to build this trust and rapport. If I think back to when I started as a nurse, the interpersonal skills of the infection control nurse were sadly lacking, shall we say. So it didn't really get, there wasn't a lot of two-way. It was do this, do that. Know why you should do it, which I've always felt was really important, to be able to motivate people. And there was no receptiveness to feedback or anything like that. There are a number of barriers to just-in-time training, time constraints. You know, do you get an opportunity? How many times have you been to the ward to talk to somebody, a member of staff, and they say, "Yeah, look, I really just haven't got time at the moment." So how can you fit it in? And we know that's an issue because we are hugely understaffed. So that's a problem for us. Our knowledge and experience gaps. If you're new to infection prevention, how can we develop confidence in people so they can deliver impromptu training? And you may need knowledge beyond just the just-in-time training scope. I've always found, actually, if I don't know, to say, do you know what, I don't know, I'm not sure about that, but what I'll do is I'll go away and research it and I'll come back to you. I've never had anybody go, well, they should know everything. Even though we may think we're experts, I've never personally felt that I am a complete expert on anything. So I don't think there's any issue in saying that's a really good point. I'll go and check on that and I'll come back to you with the definitive answer. Sometimes a barrier is the workplace environment. If you've got a chaotic clinical setting, which is present in many places in the health service in the UK at the moment, there could be staff resistance, especially to change or lack of engagement because of the pressure they're under. And here we go. There has to be a bit of a what's in it for me, I think. Resource limitations. Are there tools for just-in-time demonstration? You know, I have seen people, though, take little trolleys around with the equipment they need. And so you come in with all your props, you do your just-in-time training, and on you go. And I think that it works extremely well and often evaluates very well. I can see that Elaine Overton's on this call. Elaine will put together a little kit, will go around, teach people how to decontaminate a piece of equipment, takes a few minutes, and then she moves on. And that sort of thing actually can go down very well because you've not to go and find things as you're going. And the communication challenge and getting consistent message across a diverse group of staff, that's an issue. So those are the barriers. The facilitators, if you can get the organisation to support it, great, especially if you've got leaders who endorse it. And will maybe even allocate some time and resources to do this. And it may well be when you're building your business case for your team, you have to say to people, do you know what, I would love to be able to do this just-in-time training, but we haven't got enough staff. So we either give up doing some surveillance or give up doing something else and switch it to on-the-spot education. Our problem with that at the moment is we haven't got any good evidence to show it's going to make a difference in terms of reduced infection rates, and we really do need better studies from that sort of thing. Can we provide good training materials, visual aids, quick reference guides? You know, I've really quite like the idea. I've seen people put QR codes all over the place, lots of information going up on that. That can be useful. What about the skill development for us as infection prevention practitioners? Can we get some training programs on communication and adaptability and impromptu education techniques? You know, why not at an IPS conference run a stream on education techniques? You know, I think that would be a useful thing to do. Can we get people into mentoring opportunities? I know the IPS do that. That would be very useful. Can we get time training incorporated into daily infection prevention rounds? You know, what sort of difference might that make to create these natural opportunities? If you know there will be a huddle at a certain time, can you get in on it? And so trying to get the culture where real-time feedback is actually normal and valued. You know, come and tell us how we're doing. Because if we can go along and put in time just-in-time training, you can switch that instead of what people would have perceived as criticism of our practices in the past. Hands-on demonstration, role-playing scenarios all go down very well as well at this point as well. So I think there's lots. Now, simulation training is what people really want to do, but they aren't doing it at the moment because they don't have access. And there's certainly some skills you need for effective simulation training. You've got to have the technical expertise. So you've got to be able to identify and replicate realistic clinical scenarios. But what you could do is ask the staff, what clinical scenarios do you struggle with most? Where do you struggle with either the decision making or the practicalities of it? And we will construct a clinical scenarios that means we can run through that. Yeah, the designer facilitations skills there. Can we make it engaging and meaningful? And can we get a good debrief session afterwards? Having a relaxed environment so that people will open up in a simulation session as well, so there's constructive feedback. David Webber did a nice piece of work where he actually had peers going in and doing the feedback rather than infection preventionists, because they were seen as outsiders, but trained peers who actually had skills in central line management was seen to be supportive, whereas maybe an IP wouldn't have been. Can we tailor this situation to different audiences? Can we change the learning objectives? Can we adjust them dynamically based on participant needs? Because people's needs are different. But what you will need is familiarity with the simulation tools, including the mannequins. And do you know what I'd love to see? Because the mannequins are quite sophisticated these days. If you were doing central line training and somebody didn't do one of the 5 aspects of the bundle, they didn't clean the skin properly with the alcoholic chlorhexidine or whatever substance you're using, or they didn't scrub the huff before accessing the IV line, so the mannequin would automatically develop the signs of sepsis instead of it being 2 days away and nobody realizing it was them. If something goes wrong, the patient immediately suffers an effect where you can immediately do, okay, let's do a quick root cause analysis. What could we have done better? Maybe it was that. I think that will make a difference, because people might at that point think, was that me? Problem with simulation training is there's lots of barriers, like getting into the simulation suite for a start. The equipment's expensive. It's generally focused towards training doctors in technical procedures. That is an issue. So you've got limited availability of dedicated training spaces if you're using the mannequin or the clinical skills lab type of scenario. There's probably times limitations as well, competing priorities. Can you get the technology working? So the technical challenges as well. And if the equipment goes wrong, that can be an issue. And lack of facilitator training. So often the organizational support is a real issue for us. But if you can make it work, the facilitators are the organization recognizes this is a good thing to do. So therefore there's leadership support for that as well. If you can get good scenario design, and there's no reason why people shouldn't share their scenarios. I don't know why there couldn't be a group of people who come together and design a set of scenarios and then share them around. Have you got facilitators who can guide people through this? It's a skill to facilitate a simulation training setting, and those working in clinical skills could be trained to have the infection prevention knowledge if they're brought into the team, and maybe they're brought into the team for a short period of time to actually get some better understanding of infection prevention and control. Could this be embedded into other educational initiatives, and updating scenarios with what's current in the hospital is also really useful. If you're seeing an increase in C. diff, change your scenarios to look at C. diff. If you're seeing an interest in multi-resistant gram-negatives, change the scenario. If there's an increase in respiratory viruses, or you can predict flu season coming or norovirus season coming, change your scenarios and put people in that sort of situation. So I think there is potential. Now, where I also think there is some potential is using adaptive learning technologies. Okay, and this is sort of moving into AI type of role, because the problem is people come into a learning session and you're trying to do something that one size fits all. So there's always going to be some people in the room that you're going to be teaching to suck an egg, because they've done it before and they absolutely understand it. Whereas adaptive learning technologies could be use machine learning to personalize this learning experience, so they can dynamically adjust the instructional content and the pacing and the resource to meet the unique needs of an individual learner. So it's almost like an e-learning, but actually it's overseen by somebody with experience. So the goal is to try and optimize engagement. You do an assessment of where somebody is, what their knowledge base is, and then you work with that. You work from that point on rather than go through all the basic bit again. I think that would be pretty useful. So what could these sort of things provide? Well, you could get a personalized learning path for a start, so the content's customized based on the individual strengths and weaknesses and their pace of learning. You can use this then to give some real time feedback and adjustments. So, if the learner gets immediate feedback, then the system adjusts the difficulty on the type of content. So they might, if they get some questions wrong, the system will work out, okay, they clearly need some knowledge in this area, therefore I'm going to feed them this content. Whereas if they clearly have an understanding of a certain concept, then you can move on to a more complicated concept, or you can maybe ask them, do you want to learn more about this? And you can funnel them off down in another direction as well. But if they get a topic wrong, then the education system may provide additional explanations or simulations on the same subject. You then get somebody with an overview of this who has got some data-driven insights, and they can collect and analyze performance data, looking at learning behaviors and progress. And a module leader can actually view a dashboard and see subject areas where the whole group is struggling, and therefore may need to adapt the training. Maybe the training is not being provided in a way that's helping people understand it. That's really important. You can do continuous assessment. There can be quizzes, which can be, you can make quizzes funny. You can make them interactive, which will help adapt the learning process. And actually, if there's something like Duolingo is a good example of this, it will increase in complexity as you get more proficient and in vocabulary and grammar, but it's done it in an engaging type of way. If you're trying to learn a new language, that can work very well. And you could even add in games and other engagements. So, maybe you have a level, I've reached level 4. I'm striving to reach level 5. People actually quite like to see some progress. Another method I came across in the literature when I was looking at this was doing some digital storytelling. And I felt this was an interesting paper published this year in the Journal of Computer Assisted Learning. So this is looking at digital storytelling on nursing students' compliance with isolation precautions. This is a pre and post test randomized controlled trial. And they use tools like Pixton for story creation. So Pixton, if you have a look on their website, if you just type in Pixton into Google, you can actually create comic strips. And people can find this quite engaging. So they actually create their own scenario, and they got feedback from the tutors on the progress of that. And I just knocked up this in about 10 seconds yesterday. This is an outpatient setting. I think the patient's got something called CRE. I wonder what I should do. Well, the patient looks all right, so I guess I can do nothing. Is that right or wrong? And then you can move on. And Padlet is an area then, it's like a big bulletin board where you post your story on this large board, and other people can look at it and give you some feedback as well. So it's a very, very interactive form of learning, and I thought it had some potential, but not published in a journal that we would normally pick up on. And what they found was this digital storytelling did improve students, nurses' compliance with isolation precautions and their knowledge retention compared with traditional methods. So the experimental group got higher post-test scores in compliance and knowledge. There was actually better retention with a smaller decline. They all declined. Nobody keeps everything forever, but there was a smaller decline in knowledge and compliance scores 2 months post-intervention. I would like to see them done it at a year, because that's when you know if it's really gone in. But what happened was the staff were reporting that the method was engaging and did promote reflective learning. And they found that higher compliance levels were actually strongly correlated with the higher knowledge levels about isolation precautions. So they felt that actually people creating their own story with feedback did breach gaps in understanding, making sure people were better equipped to follow the protocols. I'm just going to finish off with a couple of comments about education versus training, because I personally believe there's a big difference, and motivation plays a big part in both of these. Now, education means we give people a knowledge base. It's a longer term knowledge base that people have principles and insights then act as a driving force for when you go forward. And I think this is a really motivational aspect to that, because I learn better when I'm interested in something, and you have to know why, I think, before you will then want to learn. Okay, I will then do it because I understand why. Whereas training can be task orientated within a specific working environment. How do I clean a commode? How do I operate this wash and disinfector? And this is helping staff to acquire skill to complete a procedure to a set standard. I personally don't think, well, that unless you give people the education, they will start when they've been trained to perform a procedure to a set standard, looking at actually how can I shortcut this. Whereas if you educate people, then they understand why it needs to be done in the way that you've specified it. So to me, there's a lot of motivation to be done in education. That can be internally, people's individual desires. They've got an interest in this, or a personal satisfaction, or you work off their desire to actually learn and further themselves. You know, people pursuing epidemiology because of passion for actually understanding disease transmission. And if anybody ever does understand disease transmission, I'd really quite like to talk to them. Other intrinsic motivations comes from external awards, grades, recognitions, career advancement, etc. So doing your coursework to get your degree so you get a better job or something like that. How can we do that? Create meaningful and relevant content that aligns with learners' interests and people's interests. You know, why might they want to learn something? I don't want to do damage to people. I want a better job. You've got to learn why they want to do something before you can actually work on what their motivation might be. They might not want to, might not want to be the worst ward in the hospital, or they might want to be the best ward in the hospital. What's going on here? So I think encouraging some autonomy by allowing students to choose their topics or projects is good. And if they've got a particular issue, I might want to teach them about CPEs. They might want to learn about C. diff. I'll work with that. I'll get their interest going. Then I'll bring them back to CPEs. Providing positive feedback, celebrating progress to build confidence is important. And motivation training is really important as well. People should be driven by a desire to improve and contribute to team success, master a skill, and that could be like a healthcare worker learning how to cannulate in a clinical skills lab. The problem then is trying to find somebody who can supervise you in practice, which means they never ever cannulate again after they've left the clinical skills lab. That could be an issue. So the motivation to learn a skill maybe isn't backed up by practice to actually help you exercise that skill. That's an issue. Extrinsic motivations, you're motivated by, again, certifications, promotions, or appraisals. And what's wrong with actually giving members of our hotel services staff or environmental service staff a new status, recognized for their skills in being able to use new technology to meet the job requirements, rather than just crack on with that, and we'll show you how to use it. But people should feel proud that they've actually learned a new skill, I think. So strategies to enhance motivation in training, highlighting practical benefits and skills that what you're being taught, how this does improve job performance or patient outcomes. If there are improvements in patient outcomes, keep telling people about it, because that is very motivating. It's nice to know that actually what you've done is successful. That's really important. And I think immediate actionable feedback is absolutely critical. So I think I'm going to hop Scott the last two slides, because I'd rather get on with the discussion. What I would say, lastly, though, is just evaluate what you do. Find some way of evaluating. And you might be pleasantly surprised. Some people, I'm not sure I want to do evaluation. The good news is you're never going to be the worst to evaluate part of mandatory training day. That's the role of data protection or manual handling, so that's fine. If you do evaluate, you can show the value of training to your organization, both of your team and the effect of it as well. So it may help you argue for access to more training or to provide more training. And I personally believe that all training should be evaluated in some form. So there we are. I'm going to stop sharing now. I'm going to stop sharing that window and open up for discussion. Although what I did want to do was share something else. And I'm just going to pop this up on screen just to see if I can get it to work, really, because Mr. Otter did this. So I'm just going to share this very quickly. Where can I just want to chuck up a word cloud while I've opened up to discussion, just to see if this works. So in one word, sum up your experience of providing infection prevention control education and training. You can either go to Menti.com and use that code, or you can actually use the QR code. I just want one word. Let's see what happens. I don't know if it will work though. If it doesn't work, I do apologize. I've never used it before, but John mentioned Menti. Oh, we got, okay. Oh, you've been listening to me then.
That was me. I got in first.
Yeah, okay. Frustrating. Okay. God, none of these are very positive, are they? This is fascinating.
Thanks, Martin. Let's let those roll in as we
just let it roll and start the discussion.
yeah, let's let it roll as we start Q&A. That was really fantastic. Thank you.
Yeah, thanks, Martin. Lots of brilliant nuggets. I really like what you said about, you can teach people IPC, but you can't teach them enthusiasm and motivation. And I think when I've done training before, you've always got to try and get the audience enthusiastic and motivated. And I think starting with, in my experience, some of the ways in which healthcare associated infections can cause challenges for our patients, and the cost of the NHS, etc., is always a good way to start getting people involved and engaged. My first question really was, you talked about a fascinating number of different ways in which people can look to train and educate, and different things that we might need to be aware of, that and we might need to think a bit differently. But if you had to design a new training program for an infection control simulation or something like that, how would you try and keep the levels of education high? Because often we see, don't we, when we train, they're really good for a short period of time, and then unless you keep doing repetitive bits, it falls off. So how would you try and design something a bit differently to ensure that you stay at a good level of knowledge?
That's a really good question, Phil. And I think if I'm going to train on a particular topic, I'd be looking to train because we have a problem in some area. And therefore, I would be training to try and solve that problem, or do something about that problem. And I would be making it clear to people what the problem was and what we were trying to achieve. And I would then provide regular feedback on how it was going. And as soon as it started to dip, I'll be out saying, why do you think numbers are going up again? Is it because people have forgotten? And often it's, the excuses come, well, we've not got time anymore. Oh, yeah, I'd forgotten about that. And it's just them finding out what aspects of it were they struggling with. Okay. And it may well be that they know what they should be doing, but something else has happened to stop them doing it, which means you may have to go and find an answer to that particular problem that will allow them to actually enact what they have learned. They probably know what to do, but there may be reasons why they're not doing it. So it's working out then what went wrong. And if that is re-education, then you have to re-educate. I mean, I'll give you a good example. Brett's just published the CLEAN study, which everybody saw presented at IPS, and there was regular audits going on, okay, to check the compliance of the cleaning equipment. And when it didn't go well, when the cleaning compliance dropped, they went back in and retrained them. And they gave them feedback, non-punitive feedback, to say, look, things is, the numbers have dropped. Why do you think that is? And maybe we just go through the training again. And nobody worried about that. They were actually very happy to get the retraining because they understood that things were slipping again. Therefore, I might need to go and do this again. So if you're training on a particular aspect, I know this is a really long answer. If you're training on a particular aspect, you then got to monitor whether that actually has happened, and monitor, and that monitoring goes on. And I personally would rather spend more time continually monitoring something like that than not doing hand hygiene audits, which really don't bear any resemblance to reality. So it's about showing people that it did make a difference, and working out when it's not making a difference anymore, what's going on, and should people need retraining. And it's not saying you're doing it wrong, it's just, this is slipped, can we just do a refresher, which can be short and only 3 or 4 points out of the training that you did before.
Thanks, Martin. 33 responses, so the Menti worked really well. I've seen a couple of positives ones in there, but the majority of are negative, aren't they? I don't know if you want to talk to that quickly, Martin.
Well, it is negative, and so that's that. I mean, I think we should repeat the sort of survey that APIC did in the UK, and let's see what the experiences here are. But why are people finding it? Let's do John will hate this word, qualitative piece of work, so that we get some understanding of why this is. Is it soul destroying? Is it that you're talking to people who aren't interested? Is it because the staff don't have the time to do this? I mean, I'm actually going to screenshot this because it's so fascinating. One word I did pick up, and one way. I think that's an excellent point, and that's I sometimes I've been very guilty of this myself. I just give my talk, and yet what I haven't picked up in the room is people going, and in which case what you've got to be aware of is, if you haven't got the audience going with you, if they look skeptical, straight away jump in and go, don't you think this is going to work? Why wouldn't it work for you? And you'll get a reason, and it may be the real reason, or it may be just, well, it'll never work here. Well, that's too broad. We're going to have to narrow that down to something specific. But I think one way is an opportunity, because if we're spotting people who are experiencing our training as a negative, and it's not coming across, then either we're not delivering it correctly or we're not meeting their need. And I think it's really important that we make it a bit more two-way, so we actually do meet the needs of the learners. Now, I mean, I occasionally what I used to do in mandatory training was have a slide, and okay, I can go three ways here when we get, depending on the audience, and I give them a choice. So from this point, we can go on and talk about urinary catheters or intravenous lines or C. diff. What do you want to talk about? And I take a little vote, and we would go with that. Okay, and that, that's just to make it a little bit more to try and meet the needs. The problem is, when you're doing mandatory training, you can have all levels of staff in there, and that can be really difficult unless you can focus it.
Thanks, Martin. John?
Yeah, thank you, Martin. That was great, really fascinating and insightful as well. Question from the audience is, how can we make best use of our partners in delivering effective training? There's a lot of other teams out there that are delivering infection training. Is there any synergy, or can we jump on the back of effective programs?
Who are these folk, John? I mean, can somebody come in and say what they are, or have you got a private company coming in delivering your infection control training? Or? I'm not sure what that is.
I think this is more about other clinical directorates or teams with clinical educators that have got great rapport with the teams that we're trying to reach. So can we use them to access them more effectively somehow? That was the question.
Okay. That's a really good question. I would be wanting to try and second those into the infection prevention team for a month or so. As part of their experience, just so that they can actually answer infection prevention related questions a little bit more, or for them to keep a tally during their training of the questions that come up, so that we can actually formulate an answer for them. It's about them learning how we would think, I think, is a useful thing, or having a frequently asked questions. If this question comes up, maybe that's the answer you should give. The problem is, if somebody asks a question and somebody fluffs around the answer, then it doesn't come across as that credible. And that's often where an experienced infection prevention practitioner can help. And I've always felt that actually using the narrative, using storytelling, here's an example. Oh yeah, I remember an outbreak when, that sort of thing breaks up training and gives a bit of context and a bit of interest. And somebody who's just doing infection prevention training, or has an infection prevention aspect to the training they're doing more generally, wouldn't be able to provide. So that, they can provide some education, but I think it's difficult for them, I think, and difficult for us to try and get in with them unless we can build a really good rapport with them.
Thanks, Martin. There's really a good amount of discussion going on in the chat. People talking about how we need to innovate and move with the times, talking about making things interactive. Quite a lot of people talking about using simulations as well, which is great, and I definitely think they have a place. I attended there's the Marion Reed educational program, which runs in the West Midlands, and they've gone into developing simulations where they developed loads of challenges that are in this side room, and they have to actively go and identify what is being done wrong. And I think that's a really good way to get people thinking. Last question, if that's okay, Martin. With the advent of AI, and I know you've dabbled in AI a little bit, where do you think infection prevention and control training might be in 10 years' time?
Well, it's going to learn more, isn't it? They're large language models, so they will learn what we put into them. I think in some ways it's a good way for us to put good information into them so that they learn a bit better. But I think they could definitely help us out with providing, this adaptive training. Here's a scenario, here's 4 answers, and this answer is correct. But if they give any of the other answers, could you create a response that would help point them in the right direction. And that way you can actually use these large language models to provide a lot of your content. We're going to need to read it, but it's going to save us an awful lot of typing, especially if you're like me and I'm like this. So I think there's a lot of opportunity there, I have to say.
Definitely. I'll just close. Great comment from Heather. You always need to
she's absolutely spot on.
Yeah,
absolutely
you always need to
spot on.
identify what's going right. If you focus on the negatives, then you turn colleagues off. I couldn't agree more with that, Heather. Martin, it's always a pleasure. Really great to have you on. Thanks so much. Just before we wrap up, for those of you who are interested in future IPC Partners Journal Clubs, this is our schedule. So John and I are going to be talking about automated hand hygiene on the 18th of December, and then into the new year. We've got Alex Sunderman from the US talking about genomic surveillance for infection prevention control. And then we're delighted to have our partnership with the Hospital Infection Society, or the Healthcare Infection Society, sorry, 22nd of January, where John and I will be talking about water and the risks of water within healthcare. There's some links as well for subscribing to the mailing list, and all these recordings are present on the YouTube channel if you ever missed one and you want to catch up on them. But once again, Martin, thank you so much. Thanks to the audience, and wishing you all the best. Bye now.
Bye, everybody.